Next item on our agenda, Superintendent's Report, and I'd like to welcome Jeanne Casner, the Director of the Chester County Department of Health. Jeanne, thank you for listening to the concerns this evening. I think you got a pretty good taste of what we've been hearing from our residents, and we're curious to hear what you have to say.
Good evening, everyone, and thank you for the opportunity to be with you this evening. I think it's critically important, to continue the conversations and to continue the transparency. And I appreciate being a part of that, not only through our work with superintendents, but also joining board meetings and community forums with it. What I thought I would do is, just make sure everybody understands the general context in which the Chester County Health Department for both counties, not only Chester County, but also Delaware County, are working to support schools. So when we assist schools, we're really looking at assisting in the planning for reopening and development of the health and safety plans. We all know those health and safety plans are grounded on physical distancing, face covering, health monitoring, cleaning and sanitation, among other topics. And it is truly centered around the health of the students as they are receiving education. It is not a small task, by all means, that all of you are grappling with. I've been in this since January, and the dynamics of a school truly do present additional challenges that we have not seen in other areas and other organizations, such as long-term cares and hospitals or daycares. So we have to continue to work through this. And part of that is the health department's commitment to having a response team specifically for schools. So we have that team up and running, and the team will evolve and continue to grow as the demand warrants. And that team serves as each school district and their school's primary point of contact. So as questions arise, schools have a direct point of contact to go to. As more detailed guidance has to be developed, that team is leading it. They also are the team that completes investigations of COVID cases relevant to staff, faculty, and students in schools. They provide the additional guidance to the schools based on the results of the investigation. They engage the contact tracing team. So we have a separate team doing contact tracing. So there's a handoff from the investigation to contact tracing. So any close contact is contacted by a health department staff member, given the appropriate information and guidance for quarantine. And then, of course, our school team is here to support communications, whether it's through forums like this or written communications that may need to go out to families and staff. The health department is also continuing the collection and analysis of data. That's always important. That kind of guides our understanding of how this pandemic is playing out in our counties, while also taking in information from neighboring states and other states across the United States. So how do we do this? We do this because we are public health. We do this every day of the year for many, many diseases. Right now, we're doing it for one disease on a huge scale. I have a staff of just over 100 people, and that is the staff we are using throughout this response. And that is the staff that we pull from to create a specialized team for schools. We do have the ability to add staff or contracted individuals as needed. And we had to do that with nursing home support, et cetera. And we're well prepared to do that for schools as things ebb and flow. So we're pretty nimble. We have the support of not only Delaware Council members, but also Chester County commissioners to be able to be dynamic and not to have barriers around acquiring additional staff. Another key aspect is understanding the reporting that needs to occur between a school and the health department. So there is guidance out on when to report. Reporting immediately around probable and confirmed cases, and all schools will learn what that is. The definitions are in our guidance at this point, but the school team will also further assist in that. And that reporting is really what starts the health department's efforts in the investigation, so we can give that guidance to the school, whether it means cleaning or moving students to a different area of the building or closing a building. Our goal is not to rush in and close. Our goal is not to overreact and jump to closure without the appropriate information we glean from our investigations. The investigations are becoming more involved because people aren't quarantining at home now. We're green, so more people are out and about, which means there are more questions and more activities the individual has done that helps guide who we need to determine is a close contact. And then, of course, as you've heard with the contact tracing, I think my message to not only the school board and the school administration, but also to our families is we really do have to take contact tracing seriously. It is a proven public health strategy that has been used for decades to stop the transmission of diseases and viruses. And what we are currently running into now is people, frankly, refusing to give the health department information about those they've been around during their infectious or incubation period. And without that information, people are unknowingly out in our communities, in our schools, going to restaurants, etc., not knowing they may be actually transmitting, particularly when there's still a large evidence that transmission does occur without any visible demonstration or medical demonstration of symptoms. So a lot of what we ground our guidance on really anchors on the tenets of what we've been saying all along. They sound really simple. They've gotten annoying, I must admit, because we've been doing this a long time, but they truly are within our individual control. And that is really the masking, having an appropriate face covering on, ensuring as much as possible 6 feet separation as frequently as possible, washing of the hands, cleaning of frequently touched surfaces. These are things we have heard and we continue to preach for the last many months. These are the strategies that are going to remain important as we come into reopening schools, just like it's reopening of a daycare or of a movie theater, et cetera, et cetera. So the fortunate thing is we actually, as individuals, have a chance to impact this. And then you couple that with all that the school and staff are doing, not only communications and reminders and teaching of how to hand wash, et cetera, we're strengthening the school's ability to reopen. And I'm not saying that we're reopening in person, that is for each district to navigate, but at some point we are going to get back to in person. And these measures are going to have to remain in place until we have proven that in person can operate without these measures. So I'm going to pause there and turn it back to our school board. If there are specific questions or more information you'd like from me, I am more than happy to address those.
Thanks, Jeanne. Questions, comments from the board? Bridget?
Hi, thank you for your information and presentation. I think one thing that community members and families sending kids to school would appreciate, just going through the process of what it will look like if there is a child or a staff member in a classroom who maybe has symptoms or is suspected of having COVID. Could you just talk to the kind of the reporting, the notification to other people in that classroom or school, and the recommendations that would follow?
Absolutely. So we have a general framework in place, and the framework is intended to cover the 80% of the scenarios. I'm not going to fool anybody. None of us are going to be able to consider all the potential scenarios. But the framework will help navigate through them. And as we have new ones or nuances to existing ones, we are going to update that framework as we go. So the framework is, if an individual, whether it's a student or a staff member, is in school and starts to exhibit signs of coronavirus, they are expected to go to a separate area of the building. We're calling it an isolation room. So that individual is kept safe and can be separated from the rest of the school population until that individual can get home. So once that is in place, meaning the individual is removed, separated from everybody else, whether it's the school nurse or another designated individual will actually go online and fill out a form on the health department's website. That form goes directly to our school team. Our school team picks up that form, and whoever's assigned to that school district will begin that investigation. And that investigation may involve contacting the school to ask further information. Can I get the attendance list for any individual who was in the room at for the time that our individual of interest was? Or where else in the school was that individual if they're not remaining in their classroom? So we're pulling out all that information. We are contacting the family, asking that family additional information about their unique situation, because it may be they had gone over the weekend to a family barbecue. And that tells us something, along with all the school information, to kind of put together an assessment of what is that individual's risk right now and likeliness to have coronavirus, and what is the exposure level of everybody who's been in contact with the individual. If that exposure level is low, the school will be directed to continue the instruction to the rest of the students, or allow that staff member, other staff members who may have interacted, to stay at school. But we are going to require you to send the individual home. Okay, but others may not have to leave if it's a low risk. If it's a high risk, then yes, we may say that classroom should plan to leave early. Now, low and high risk, I know everybody wants a definitive black and white definition. It's difficult because one building is different than another building. One classroom makeup is different. So the way I've been explaining it is, and this has helped as we've worked through daycares and nursing homes and first responders, what we're looking for is schools to go all in and implement multiple prevention strategies, multiple mitigation strategies. If we're wholeheartedly doing those, we by default are reducing exposure risk. But if there is a measure or strategy that failed, let's say, for example, in this scenario, the individual is a student, and for whatever reason in that room, all the students were allowed to keep their mask off all day. And we didn't have 6 feet. Well, now your exposure is higher because, and I call that a, we have had a failure in our prevention measures. But if everybody in the classroom was respecting the 6 feet, had their masks on, we had them washing their hands, we had hand sanitizers available, they were all sitting forward, they weren't touching each other, we're probably going to deem that as a low risk and not be disruptive to the rest of the class and say, let's send them all home. And this is where the school team, by virtue of working with the same schools in the same district over and over, start to develop that relationship and that awareness of the uniqueness and the similarities across schools, and can give that guidance more quickly and with more confidence, because they have started to see some patterns in the school. That's also where we'll be coming back to the school and saying, dear school, you really got to get serious about your masks. We can't have these failures because this is the net effect of them. So while I know it's not comfortable, that there's no definitive, here's every single scenario we could possibly think of and the exact flow of how it's going to happen, we have a really strong public health grounded framework. And then from a reporting standpoint, it will be the health department's responsibility to be in contact with the individuals who are probable or confirmed cases, because we need to give them appropriate information. It will also be the health department's responsibility to be in contact with the close contacts of those who are probable or confirmed cases. So we won't be asking the school to do that. Now, the school may help facilitate it from the standpoint of, will you please send this letter or this email to all students in classroom 1A? And that's much quicker for you to do through your communication channels, but it's our message that you're helping to facilitate. So that's kind of how we see it play out. It has worked for other organizations that we've had to plan and partner and help communicate with. So you will give us the feedback if it is working or is not working, and then we're going to adjust unique to schools at that point. I hope that was helpful.
It was, yeah. Laying out the framework was helpful. Just one quick follow-on, or hopefully quick. For the person who presented as a probable case, is there going to be a standard expectation of a kind of a quarantine or isolation at home for a set period of time, or how would that be determined?
So, pardon the dog in the background. So that will be, excuse me, that will be determined by whether that, particularly for a probable. For a confirmed, they're going home and they're going to follow the confirmed period of time at home. For a probable, likely the recommendation is that individual should be tested. And then that's going to tell us, are they going to be on the 10-day or the 14-day path? Because there's a difference between the infection period and the incubation period. And that's why we have a 10 versus 14. And that's kind of laid out in the guidelines. So it's really going to be based on the number of symptoms that probable has. Have they had testing, but they're waiting for the results? Or are there other people in their household that are already confirmed? Then that gives us another direction we can take with that individual, even without a test result.
Okay. Laura, you're up next.
Yeah, thank you so much for talking with us tonight. That was extremely helpful. I had a few questions related to testing. So are individuals responsible for getting their own testing, or is that something that the health department would do?
It can be both. So we have a growing number of physicians who are doing testing. So if an individual has a primary care provider, we would start there. If that primary care provider for some reason doesn't do the testing, can't do it in a timely manner, etc., there are options. They can go to a CVS or other pharmacy. They can also go to a health department testing site. Now, those sites move around, They're not all day long, and they may have some limitations. But if we run into a scenario where we truly have a need to get someone tested, we have the means as a health department to make that happen. We did that in the early stages. We even knocked on the front door, did the specimen collection, got it to the lab. Now, certainly with the number of students we have in, any district or even both counties, that's not feasible. But it is our job to make sure that we address those barriers. So it's going to be important for families to communicate to you if there are barriers, particularly if there are barriers we have not heard about since the beginning of this pandemic.
Okay, and then in terms of the length of time to receive test results, I think we've all been hearing of, these cases where it takes 3-4 weeks to get your test results, and by then, you've already done your quarantine. In your experience, how long is it taking to get test results these days?
That's pretty unique to the lab. We've all seen in the media that some of the large commercial labs are beginning to report delays, and it's really delays out of sheer volume, not due to their lack of ability. We are seeing, we have a lab as a health department that we contract with, and it is used by both counties. That lab has a specified contract, through their contract, a turnaround time. We're seeing that they're bumping up on the higher end. Still acceptable, but on the higher end. So we're already starting to put other strategies in place, having a second and a third lab to turn over to, having additional partnerships with high capacity labs, even if they're out of state, so on and so forth. What we have to recognize is, even if our numbers aren't high, we are going to be impacted by our surrounding area. If their testing increases, even if ours doesn't, it may impact our turnaround time because of the surrounding volume. Unfortunately, it is nothing you or I can control. We just have to plan for it. So we've already started that. We've already, had communications, and fortunately, county leadership weighs in and starts to, to really push that partnership with various labs. And I'm confident we'll have a secondary lab and other potential ways of testing, even if it's tapping into more of the state resources for that.
Okay, great. And then my other question was about mitigation strategies. I think that the plan that we have laid out previously, and we're going to hear more details about it tonight, has sort of these layers of protection that we've been hearing a lot about. And so I was wondering, from what you've seen and what you've experienced with places that have already reopened, like daycare centers and nursing homes and places like that, by implementing these different layers of protection, has that been effective in these kinds of places?
Yes, and it's been effective when they're used in combination. And that's partly what we added to our guidance, is these are not standalone. You can't just do 6 feet and say we're good. And in my opinion, because I err on the side of caution, and I know there were some questions about, if students or staff are 6 feet apart, can they take off their mask? I'd rather err on the side of caution and say no until we know we're good in our schools, because schools are like a daycare, like a nursing home, from the standpoint of you're in a contained area. So we have to see how it plays out. And you're different from a nursing home because the entire population coming into the school leaves every day and comes back in. In a nursing home, the challenge was, or the biggest variable was the staff coming and going. And I'm not saying that they caused anything. It just became fewer variables. So you're dealing with a greater number of variables. So you're much like our daycares. But we have seen, even in hospitals, when hospitals have their appropriate protection, personal protection equipment on, and they're working face to face with extremely ill we didn't have healthcare infections. So it does work, but it has to work, or it has to be done as collective and integrated strategies. That's the key.
Okay, great, thank you.
You're welcome.
And then my last question is sort of related to that question. We've had a lot of experts coming and speaking to us over the past few meetings, and I think they've all been sort of generally consistent, but I was wondering if you had any other recommendations. So besides the 6 feet of distance, masking, frequent hand washing, as much ventilation as possible. It seems like those are sort of the things that we keep hearing over and over. Is there anything else that you would add or you would recommend?
Are you telling me? Are you telling me my 19-page document wasn't enough?
Well, it's more for the public than anything else. But if there was something else that you would recommend, just again, to err on the side of caution, I would just be curious to hear your thoughts on that.
So, no, I think it's the diligence and the commitment to them and the compliance. Where we see things, and we're hearing this as we do investigation now, simply people being out in public without a mask is becoming a theme of close contacts and positives. It really is. It's not all our shoregoers, it's people staying right here in our neighborhoods without a mask. And that's really simple. It's really important. What I like, if I have to like something about a pandemic like this, it's the consistency of these measures, that they truly are working. What we're dealing with is fatigue and someone's ability, whether it's a physical ability, a mental ability to comply with it. And I guess we've been at this for far too long, but there's got to be a way we can re-energize folks for the same.
Great, thank you so much. I appreciate it.
You're welcome. You're welcome.
Before we go on to the next board member, I just had a quick follow-up, which is the scenario where a student is sent home and then Chester County Health Department talks with the school, follows up with the family, and then comes back with some advice. What would you envision that the time frame is for that turnaround?
We initiate an investigation within 24 hours. Okay, any investigation A is going to take different time than investigation B. I don't have a good, excuse me, I don't have a good assessment of a standard time to turn it around, because our investigations, I'll be honest with you, they're getting more complex because our socialization is getting more, our socializing is becoming more complex. So I cannot guarantee you how quick it will be, but what we have done, and this is unique to schools, is when there is a, even a probable case, we're not going to wait, and we're doing this now, we are not waiting for a test result. We're not waiting, we're moving straight into the investigation so we can make some assessments and give some direction, because it's sooner is better than later. But I also want to, tell people, we can't panic. We can't say, oh my goodness, we didn't get the investigation done within an X period of time. Because if we panic, then we're gonna lose sight of what that information is trying to tell us, and really drive out where we need to go for either that case, that room, that school, that family, and we're going to be reacting as opposed to leading and guiding that.
So in that scenario, if that student is sent home, do we bring the whole class back in the next day?
That is the guidance we will have to make based on the initial set of information we have. And that's probably one of the hardest pieces to do, because we may be working with very limited information at that time. And what we don't want to do is overreact or underreact. And that's the challenge my department has. And that's what's on their shoulders right now. And it is a tall order, but we're hoping, working with first responders and nursing homes and healthcare providers and our grocery store, all of our essential employees for, 4 months, hopefully is going to be meaningful training and guidance and patterns that we can transfer into our school setting.
Thank you.
You're welcome.
Next board member, Antoinette.
Yeah, thanks. Again, to echo my colleagues, thank you for joining us tonight. I have some questions based on the self-monitoring and self-reporting that we're asking, of our families, because our health plan does include a lot of cooperation with the different family members, and so it looks like it'll be the case that if someone thinks that they were exposed to COVID, that they should contact the health department. And I guess I just want to know what that's going to look like. So, let's say I get a call from either, a friend or a family member or something saying, I just got a positive test result and I had, my child that I'm usually sent to school spent the night there a couple nights ago. How do I know who to call? What is the response? What is the responsiveness that can be expected to that? I guess I have two concerns. One concern would be that someone is sort of just freaking out and doesn't know who to turn to. And the other concern is if it's too difficult to contact someone, they're just not going to do it. So I guess I'm just trying to get a picture of what that will look like.
Good question. So if it's, and you're absolutely right, there is a lot in this pandemic that we're counting on the honor system and the compliance of everybody, whether it's a parent, an employee, et cetera, et cetera. In those scenarios, we've made it easy. There's one phone number, and it is the Chester County Health Department's phone number, 610-344-6225. That phone number has a tree, press 1, press 2, and it will have, it already does, have an option for if you're a school reporting coronavirus. If you suspect you as an individual, irrespective of your employment or going to school, has an option. And that is put to various teams that will walk the individual through. We're doing it actively now on an everyday basis where someone feels like they have coronavirus or they were told. We have test results. As long as the test result is in, we can actually confirm for the individual. And in the beginning, it was not uncommon. I have coronavirus, I have a test result. Can you give me your name? They're not on the test, the positive list. And some of it was anxiety, we get that. Or we can get them to give us the information through their physician. So it's gonna really depend on what information they're bringing to that call. If the information is shared with the school, then it's the school reporting to the health department. And sometimes we'll get the parent and the school, and that's okay because that school team will be able to reconcile that and then have that opportunity to say, okay, we've heard from both, we know what we need to provide guidance for. Honestly, we're fielding calls about sniffles right now. And by the time that call comes to the school team, we're saying, it's sniffles, it's okay, go back to work. Go back, and it's not necessarily teachers, but you have a lot of staff still in your buildings, prepping and maintaining the property. So we're already doing that, and that's partially where we've already started to refine our guidance. We can't answer all the sniffle questions because a sniffle by itself is not coronavirus indicated. So we've refined it. We're not looking at suspect cases anymore. We're looking at probable cases. So the next iteration of our guidance will narrow that focus. So then you as a school don't have to report as much, and a parent doesn't have to report if it's simple sniffles, because it's got to be more than that. It's got to be in combination with an exposure or multiple symptoms, etc.
Yeah, so actually that's a really good segue into my next question, which is, what advice do you have for parents who are supposed to self-monitor their children every day before they go into school? Because I do think that, you're probably going to get two opposite sides of this. One being, my child coughed one time this morning, and so, should I call someone? Should I keep them out of school? That sort of thing. And then on the other side, you're going to have people that maybe don't understand, all of the symptoms or what they should be looking for to recognize them. So again, what sort of advice do you have for parents in the district who are going to have to, we're asking them to monitor, their child every day for symptoms?
The obvious advice is to keep your physician's number handy, because they know the children. If they have a regular healthcare provider, it's tricky. I'm a mom. We all walked around saying, oh, I'm breathing different. Is that shortness of breath? Do I need to go to work? Do I not need to go to work? What we see is after that initial, and I'm going to guess on a couple of weeks, it starts to kind of find its own cadence, because people have settled in and we're beyond the initial anxiety of a change in our life. So we have been asked to do perhaps some videos on how to do that. It's really hard. I'm not a doctor. So I'd like to maybe put that back to, and maybe partner, maybe ask your school nurses to work with us on what might be helpful for parents, because we're going to ask them to be a pseudo, doctor each morning. And it could be that we even prioritize on what are those symptoms that, because you've heard fever was the top symptom. Now fever is kind of going down in the, pecking order, if you will. Never did we hear about loss of taste and smell until more recently. So the challenge is some of these may even change throughout an academic year. And we just, it's a tough one. So I'd love to maybe collaborate on that with your school nurse, because, they know your student body. They know what they're used to hearing and seeing from a student population.
Okay, great. Well, again, thank you so much. I really appreciate you being here.
Very welcome.
Next up, Kristen.
Thank you for being here, Director Casner, and for taking our questions tonight. I just want to remind the public that the reason we are consulting with Chester County Health Department is because we do not have a health department here in Delaware County. And we're paying quite a bit of money to help you ramp up your capacity to support us. So we thank you for taking on our county. So I just wanted to tag on to one of the questions about self-reporting. For our multilingual families, are there options to, how can they report if they speak other languages other than English?
Absolutely. So we have Spanish-speaking Spanish-speaking staff on staff. Some of our staff, their sole role is to interpret. That's what they do for the health department. That's what they do for this pandemic. We also have access to, you may be familiar with it, resources like Language Line, where there's a third party on for the languages that we don't have staff members who can speak it. And that has been effective. We've used that on our phone banks. We've used it for direct consultation. We used it for investigations and contact tracing. So we are fine. We have access to lots of languages there, and that is built into that service that we have through the health department.
Great, thank you.
You're welcome.
And you mentioned that there will be teams assigned to each school or school district. I'm just imagining a scenario where we go back to school and after a few weeks, worst case scenario, there are a lot of cases popping up or a lot of suspected cases. Do you feel that your department has the capacity to support the school districts both in Chester and Delaware County?
I just heard the number that there's 92,000 staff and students in Chester County. I'm not sure about Delaware County. It's big. So it's really how we're going to scale it is really going to be determined by what percent is going in person versus not in person. If we have a large number of schools and districts committing to any level of in-person, even if it's just special ed and ELL students come in person and everybody else is, irrespective, we're going to scale. So right now, the team is our core team. And you have the best of the best. You have the individuals who do this every day as a part of their regular job, plus additional people who already are used to working with schools in their other capacities in the health department. They're our core, and then they will begin to train others and bring them in and be the, again, the extension of our team as we need it. So we're already planning to expand, and we can always reduce if we have less in person. But my assumption is every school district, regardless of where they start, their goal is to get to in person, whether it's this academic year or the next. And if we're still managing this, my team has got to be able to follow it along and be able to scale with it. So I've talked to at least Chester County leadership to say we need to start adding more now, particularly because our core team they're already active and they're already up to speed with all of the guidance. And fortunately, the guidance is not that different than what they've been using for the past 6 months during this. It's how do we now teach, frame, and revise specific to schools, because you're now our audience, because you're becoming active as opposed to our long-term cares. They're kind of coming off of that wave. We still have to maintain those, and that's a whole nother team that we have set up.
Thank you. So I know there's been a lot of talk around the mental health benefits of students returning to the classroom. I think what's left out of that discussion is that the classroom is going to look very different than a normal classroom in terms of social distancing, masking, all the various protocols that'll need to be followed, not to mention classmates potentially being removed or teachers getting sick. And this just sounds like a traumatic way to do school to me. I don't know if you have any thoughts or if you've heard any expert opinions around trying to strike that balance of, bringing kids in for the socialization and quote unquote mental health benefits, but also training them to be, it's going to be emergency learning again, just in person this time.
It is. I think if we have heard that guidance on how to strike that balance, we wouldn't have this question. I don't think it's there yet. I have, 2 school-age children. I struggled with the online for the short period of time. I know how my 2 are going to react if they go in person, whether, particularly if, with just the general physical dynamics of it all. In my mind, I have not heard any good balance for that, because it is going to have an impact. And I think someone had mentioned, and maybe it was in the public comments, the notion of this is going to be trauma. This whole pandemic has been and will continue to be trauma. Where I lean to you as education experts is being able to identify, is there anything we're adding to that trauma that we could have an impact on? And if so, I'd love to be a part of that, whether it's through my department or another county department, such as the Human Services that works with, mental health and intellectual development and, fill in the blank, that we may want to bring in and leverage a little bit more. We have an Adverse Childhood Experiences and ACEs coalition in Chester County. We draw upon them for input, guidance, whether it's messaging or be aware teachers, you might have to, navigate these different scenarios if you're in person that you hadn't considered before. So I don't claim that I'm the expert on it. I draw on those that surround me that do it on an everyday basis.
Mm-hmm.
So sorry I don't have the crystal ball for that one.
That's okay. I think I had one more question. Let's just see if I can find it now. Another concern for me is just the risk to teachers. I know we're focusing on students and their well-being, and that's incredibly important and absolutely needs to be a piece of the discussion. But I do worry about our teachers being in the building in a hybrid model 4 days a week, exposed to multiple cohorts of students. And we know that COVID, or at least the research at this point, is showing that COVID can more adversely affect adults than younger people. Are there additional precautions we can or should be taking on the four-pronged approach to hygiene and safety? I don't know if there's an answer to this. I just want to find a way to make sure we're having our teachers walk into the safest possible situation.
Absolutely. And the really early discussions around schools were so focused on kids. And I said, stop. It's the entire population. It's the secretary, it's the principal, it's the maintenance, it's the coach, it's everybody. And I would say that regardless of what the trend in transmission is, because we're all together in a building and we're interacting. So the plan, I shouldn't say the plan, I'm sorry. The guidance the health department has given is irrespective of student versus staff versus faculty versus administration. It is for everybody. The adults in our schools truly have a higher ability to actually comply, to wear the mask and not play with them, to not rub their eyes, to be consistent with their hand washing, to not share utensils, etc. To not just to be the model for the students, but for themselves. So the guidance is the same for everybody in my mind. My underlying assumption is the adults are going to be more likely to be able to actually carry it out. And all of the guidance is doable when it's the individual. Clearly, we have to rely on the school's sanitation and cleaning. But most of the guidance is really centered on us as individuals. And that's where, and I think we even use the words empower staff, that their mask is for them as much as it is for the students.
Thank you. And just one final follow-up to that. I know HIPAA regulations can prevent us from explicitly naming who has contracted a case of COVID. But I feel like once we get into a classroom situation where we have smaller cohorts of students, a certain student is absent for 14 days or the teacher is absent, is there anything in the guidance about how we're maintaining or protecting confidentiality? It seems like it's almost impossible at that point.
It is nearly, it is risky with that. So schools are not going to communicate names. Health departments are not going to communicate names. Schools have to strike that balance of the communication. And I know in Chester County, I talked to our school district saying, we can't do what we did in the beginning. And this was before Delaware County was under, our health department here in Chester County. In the early stages, every hint of an exposure or a symptom was communicated. And I get the reliance communities have on their schools to be communicators, but it frankly became way too much. So in Chester County, this time we said we cannot do that. So some of it is we have to set the expectations before the doors open. Even if it's virtual school, I truly believe the expectations families in the community of the school have to be set. Because, and I'm already hearing this from school districts, our recommendation is indicate that your first has occurred and you are still being diligent about all the procedures and processes and prevention strategies. But you put it out there, yes, we've had our first positive, and we're continuing our great work. We're following the plan. We're safe. After that, our guidance is don't over communicate after that. But everything I'm hearing is you say it once, communities and families are going to expect it every time thereafter. So we're working through that right now to figure out, is there some general statement that can be made? But it's the same thing as any other communicable disease you might find in a school, pertussis. You can kind of look around and see who's out of school, and oh, they must have been the one because we got a letter that pertussis is in the school. So it's difficult, but we just have to agree, we're not sharing personal information on any level, not just the name. It may not even, we're not even going to the gender, the age, or anything on it. Yeah.
Thank you.
You're welcome.
Next up, Dave.
Okay, well, first of all, I also want to thank you for being here this evening to chat with us, and also thanks to Chester County for adopting us as well.
My pleasure.
We'll be health department here in Delco pretty soon, but we do appreciate it. So I had a couple questions to ask. One of them was with regards to screening. We've had a few, and most of the guidance that's out there right now asks for some level of screening, whether it's a symptom screening prior to showing up, whether it's temperature screening at the door. We've heard varying things about the effectiveness of that. It can yield a lot of false positives. It's not exactly the best, not the most effective way in determining, who may be at risk. I just want to get your thoughts, I guess, on screening. Are there any certain methods that you believe would be best to utilize? Do you think it's, maybe on the lower tier of the other approaches that we're taking for mitigation?
So I do think screening is effective. It really causes people to pause and take accountability for themselves, or in this case, their children as well, in sending them out. My employer, the county, I'm required to screen every day. Now we have automated it where we can, go on our phone, record stuff, and, we take it to a very serious level. Our HR department gets notified if I report anything that hints at the symptom. So there's a whole series of questions we ask. Very quick, very efficient. Now, the state's guidance is have that done at home. That's where some of the challenges start to lie. So does a school district invest in a tool and a mechanism for parents to do that at home? Or do parents just do it at home on their own? I know what I prefer, something that's more consistent and has some visibility for the school, but I also recognize that that's an investment. It requires time. It's going to change. I mean, ours just changed yesterday to include travel. So I know there's that whole level of how much more confusion can you add to this? How many more steps after brushing our teeth and making sure they comb their hair before we send them out the door? So I do think it's effective. Honestly, I don't know that I've heard much from schools on how they're going to go about it, except to just have the parents do it and report accordingly. Now that report is only if you're, in my mind, it's going to ultimately probably be as on that end of this option list, it's going to be, you're going to hear that someone is going to be absent for the day.
Okay, that's fine.
But so if I could add on to that, if that is the mechanism being used, I would advocate schools ask, why are you absent? Because if it is coronavirus related, that's when you need to know and we need to know. But if it's no, they broke their foot, they need a day to recover, great.
Okay, great. The other question I had, when we're looking at a hybrid reopening because that's the way that we're able to achieve 6 feet distancing. I just am wondering, is there an, I don't know if we're overthinking this or not, but as far as cohorting children and sending them to school on different days, we're considering maybe sending them one group there on Monday and Thursday, another group Tuesday and Friday, but then we're wondering, well, is it better to send one group there Monday and Tuesday and, make the days consecutive and consistent? Do you think that there are there any benefits to either approach or drawbacks to either approach that you can that you can think of? Just kind of which would be preferred? Is tracing easier for one? Is it not? Is there anything with regards to cross contamination that we should worry about? Cohort A goes there on Monday and B goes to the same room on Tuesday. Could that provide a bigger risk than if A went there both days and then was clean, and then B went there on the next 2 days?
So you're going to have to clean the room, just your general regular cleaning every day, right? So we're not walking into a contaminated room the next day, even if it's AA and AB. Cohorting is always good. It's good from a, managing who is with whom. It's good from an investigation standpoint. It's good from a contact tracing standpoint. And that's where you'll see in our guidance, assigned seats is another fashion of cohorting. So it's a very quick, it helps in the turnaround time as well. But I don't have an opinion, and I'd be happy to ask my team if they did, whether group A comes in Monday, Tuesday, and then versus group A Monday, group B Tuesday.
Right.
I don't know if we're at that level, but I'd be happy to ask my staff if that's of interest. But cohorting in general, firmly support. We did it in other organizations, and it works.
Okay, great. Just one more, or 2 more questions actually. I guess one of them is with regards to teachers. We talked a lot about students testing positive and what the protocol is for that, or a student experiencing symptoms, what the protocol is for that. The same thing for teachers, or is it a different?
Absolutely. Yeah, we're not differentiating. We want the schools to have one process for all people, to include if you happen to have a visitor or an ancillary staff member who's shared across buildings. Yes.
Okay. So would that run the risk, I'm curious, would that run the risk of a teacher having to leave a class during the middle of the day? And should there be a backup plan, I guess, if that's required?
You should plan for that backup plan.
Okay.
But I think that's true even if all of a sudden there's flu-like symptoms in a teacher.
Right.
We want that.
Yeah. The teacher has to leave, and then suddenly there's a group of 20 kids or 10 kids.
Right.
Now what do we do? So we should have backup. Okay, good. So I wanted to make sure that was out there. And then the last question, and this one might be too complex to answer. We're already at 9 o'clock now, but I guess one question I had also was about one of our challenges is with regards to busing. PDE released some guidelines for busing. I won't go through them all, but I mean, they're generally the masking on the buses, the seating members of the same family on the same seats. Do you have any thoughts, just as a general rule? I mean, I don't know if you remember all the protocol for busing, but do you have any additional recommendations for that?
So if you haven't read our guidance on transportation and busing, I encourage you to. In addition, and this was a recent recommendation from my staff that hasn't made it into the guidance, is we support 2 people to a seat on the ends of the seat, even if they're not family members, because we want all the kids facing forward. Hopefully the bus routes are not an hour long, but when you add on the strategy of how that bus is filled, so our investigators have recommended you fill the bus from the back seat along the window on either side, and then you start to fill along the aisle on the back seat. So the person who got on first is on the bus the longest, but is going to have less time sitting, having a second person in their seat, because the folks getting on at the end of the route are getting on there. So it's like this, you know, you're almost serpentining the bus. And we were going to try to diagram that out if that added any value, because it's about the time, right? So if we're saying no eating on the bus, let's minimize talking, mask must be on, facing forward, hands to yourself. Again, all things in combination, and hopefully we can get the kids there and then into a bigger space.
Okay, that's helpful. I appreciate that. The
Absolutely.
serpentine approach, I guess, if you will.
Yeah.
Okay, great. Thank
You're welcome.
Thanks.
Before we go on to the next board member, I'd just like to point out that 2 hours ago, CDC revised their recommendations for schools. It's now posted on their website. So, you know,
What's new?
what's new?
Yeah.
Before our last board meeting last week, you know, that's when Governor Wolf revised the 3 feet up to 6 feet rule. So again, to the public, this changes, you know, at the drop of a hat, and we expect it to keep on changing. Dr. Rushi, did you have a question before I go to the next board member? Or?
No, I was just going to comment that that will be tonight's reading.
Does that mean I can count on you, Dr. Rushi, to update me tomorrow morning? Excellent. I'm going to bed early.
Kristen, you have your hand up again?
I think Laura had hers. Laura, do you have yours up before me?
Oh yeah, I do. Okay. So my question was about masks. I think there's a lot of confusion in the United States in general about what kind of mask is okay. I keep seeing people with like the regulator mask that you would use for painting your house, and I've heard those are not safe. I've seen people with all kinds of homemade situated, like I feel like everyone has sort of seen it all. And if masking in schools is going to be, it sounds like one of the best ways to keep everybody safe, it would be great if everybody had the most effective kind of mask and knew how to wear it properly. So what recommendations do you have for families about the kinds of masks to buy, the kinds of masks to avoid, and then maybe resources that we could share out to families and teachers and everybody about how to properly wear your mask, how to properly dispose of your mask, things like that.
Yeah, I'm going to start with the end of that, because we do have resources on the health department website. So I'd love to share that with Dr. Rushi. She can get it out, or you can link to it on your website, how to make a mask, the material, washing it, all of that's been out there for a while and it hasn't changed. Doing a cloth-based mask, the most important thing is making sure it is cotton-based so you can breathe. For me, I need a mask that has a little bit more space. It forms here, but it gives me a little depth here, because when I breathe in, I don't want to be eating the mask. But that's my personal style. So masks need to be up on the nose and down to the chin. And the masks need to be, you know, where it's enclosed here, because that's what we're trying to keep from escaping the particles. That's what will keep it. The typical, and I probably should have brought in some masks here. The typical blue surgical masks, those are great. The cloth masks are fine. They're both pretty equal in their effectiveness. There is no evidence indicating that our general population needs to wear the N95 mask, which, you know, is typically used in our healthcare and other industries. It's not necessary. You know, we're not face to face all day long with very ill people. If a shield is being used, that shield should come down below the chin, because I've seen some that are mid-chin, and should come to here, not mid-cheek, if a shield is being used. And the Secretary of Health at the state's order for universal masking does allow for a shield. So I'll point to those resources. And maybe one other tip, the masks that have the little wire in it to go along the nose is super effective. It seals it a little bit better. It's comfortable. It keeps it from falling down. And for those who wear glasses like me, it prevents the fogging.
I know, that's really helpful, actually. Yes, I know. I'm a
Yeah.
college professor. I'm not sure how that's going to work out with teaching and the mask and all that. It's going to be
Yes.
experience.
And then there are the improvements in masks that have a clear opening for those who are deaf, hard of hearing, prefer to read lips. They're really getting improved. Originally, I thought they're kind of creepy and scary looking, but I've seen some as recently as yesterday. Someone sent me a link to them. They're really nice looking and fit much better with it. So if students are in need of that, that's another an option as well.
Great. Thank you so much. I appreciate it.
You're welcome.
That's helpful.
Kristen?
So I think one of the more difficult things about all this has been the enforcement piece at all levels. Just even like guidance we're seeing coming out from the state is just that guidance. There's language such as should do or strongly encouraged. I guess what I'm trying to understand is, and this might be a more logistical question for the district, but how we are going to teach our students to follow these protocols. The protocol you explained for the bus sounds great in practice, but I also know that buses can be the Wild West and our bus drivers are already overtaxed. I just want to make sure that as a district, we're thinking about how we're going to support bus drivers, how we're going to support teachers, and really what the first days of school are going to look like. Because I think that's just going to need to be time to teach into all of these protocols to make sure that we can have a healthful school year.
So the added value you all have is you have fabulous educators. This is what they do. They've taught already the kids to not open the door for the stranger, keep the school door open for the stranger. There's so much that we need to draw from as educators to do that. Now, if it is, me personally, I'm mentally envisioning for my kids, the first couple days isn't reading, writing, and arithmetic. It's here's how school's gonna look and feel and operate now. We're all gonna go and wash our hands. I need, everybody, friction, 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 water, etc. And unfortunately, we have to build that into our time if we're doing in person, and allow for that and not assume we're going to have to just piecemeal it in among the reading, writing, arithmetic. It's a commitment that the school has to make in order for it to be effective and continually come back and remind it. So there's, in our guidance, it's, simple cues of maybe the morning news includes reminders, or I know the principal who is with my kids' school, he loves to use jokes to get the kids to want to do what he wants them and needs them to do. And it happens to work in that school. But he's an educator. So he's leaning on that skill, and that's what I would employ all of our school districts to do when it comes to teaching that. And if there's something we need to help with, by all means, we're in it with you. But we're also going to look to you as the educators to help with that. And frankly, part of it is educating the parents as well. And that's a piece we have tried to do between the beginning and now, but we'll also be having to do more of it with and on your behalf.
Thank you.
Mm-hmm.
Any other questions from the board? Any questions from the administration?
I don't have a question, Mr. Feinberg, but I do, want to thank Jeanne on behalf of the team. I've mentioned previously how I came across other individuals, and it was, through county meetings that I've had the pleasure of meeting Jeanne, working with her. She gets a lot of really tough questions when she's meeting with superintendents. I will only speak for Delaware County, but very difficult questions thrown at her, and always follows up with, do you need more information? Is there something else that that we can do for you? So I do feel that we have a partner here at the Chester County Health Department.
Great. I am glad you think that. That has been my big mission. You've all have asked fantastic questions. And I hope everyone listening to this understands that these questions are out of passion and care for the health and safety of the students and staff in your school district. That's what keeps me going, your guys' passion. You're not pushing this away. You're not afraid of it. You're standing there with the health department, and the health department wants to stand next to you and get through this. It is what we do, what we're committed to. So tough questions or not, whether we have the answers or not, we're always learning from each other, and we're committed to applying it and figuring it out if we don't have it to apply. So I applaud you all. Keep up the great work, and thank you for the opportunity to participate tonight.
Jeanne, thank you very much. Please thank your colleagues. We
Absolutely
appreciate the good work that you all are doing for us, and I'm sure you're going to have a very interesting year.
It will continue. As I said to others, we are writing this textbook together.
Well, thank you very much.
All right, you are very welcome. Have a good evening.